Hello doctors. Today our topic of discussion is congenital diaphragmatic hernia. Before going into the congenital diaphragmatic hernia proper, we will see the development of the diaphragm. Development of the diaphragm starts at the 4th week of gestation. The diaphragm is developed mainly from the four things. Number one is the anterior central tendon, which is derived from the septum transversum, the dorsolateral segment, which is derived from the pleuroperitoneal membrane, and the dorsal crura, which is from the esophageal mesentery, and the muscular portion from the thoracic and the intercostal muscle group. Here we can see the four part. Number one is central tendon, that is from the septum transversum. Number second, here we can see from the membranous or pleuroperitoneal membrane, which is the dorsolateral part. And number third, this is the esophagus. This is the esophagus, and this is the esophageal mesentery. From the esophageal mesentery, the dorsal crura develops. And number fourth is the muscular portion. This muscular portion is developed from the thoracic intercostal group of muscles. So this is the development of the diaphragm. Now we will see the development of the lung. The development of the lung is on 5 phases. This might be new for you. The development of the lung is in 5 phases. Number 1 is the embryonic phase, that is from the 3rd to 6th week of gestation, where the trachea and the lung bud develops. Then we have the pseudoglandular stage, that is from the 7th to 6th week, where the bronchioles are formed. We have the canalicular phase from 16th to 24th week. The pneumocyte type 1 and type 2 pneumocyte are formed in the canalicular phase, and this type 2 pneumocyte produces surfactant. Okay, and number 4th is the saccular phase, which is from the 24th week to the term. So this is important, you have to remember this. In the saccular phase, the baby is already in term, and formation of a respiratory unit means, what do you mean by that? Baby can breathe independently now, after the formation of the saccular phase. Now, saccular phase, after the saccular phase, we have the alveolar phase, that is from the term pregnancy to the 2nd year age of the child. This is the phases: embryonic phase, pseudoglandular, canalicular, saccular, and alveolar. In embryonic phase, the trachea and the lung bud happens. Then the pseudoglandular stage, we have the terminal bronchioles. And then in the canalicular stage, we have the alveolar ducts and the primitive alveoli. In the saccular phase, the gas exchange starts. This is important. The gas exchange starts in the saccular phase, and we have the alveolar phase. Then, and the alveoli, that is from the term to the 2nd year of the child, we have the septations and the multiplication of the alveoli. Now we will see the congenital diaphragmatic hernia. You have to know that previously the congenital diaphragmatic hernia is known as an surgical emergency, but now that is abolished. The congenital diaphragmatic hernia is a medical emergency, not a surgical emergency. We can treat the congenital diaphragmatic hernia later on. So, congenital diaphragmatic hernia defect is present in the posterolateral segment of the diaphragm, and from the foramen of Bogdalek, the abdominal content, from the foramen of Bogdalek, abdominal content go to thorax. Here the important point that to remember is, number 1, the congenital diaphragmatic hernia is mainly the Bogdalek hernia, which is defect in the posterolateral aspect of the diaphragm, which most of the time MCQ is asked. And another thing we have to remember, there is another hernia, that is Morgagni hernia. Morgagni type of diaphragmatic hernia, where there is anteriorly the diaphragmatic defect is present. That is not so common in child. Congenital diaphragmatic hernia mainly consists of Bogdalek hernia. The incidence is 1 in 2600 or 3000. 80% of them are left-sided. So majorly 80% is left-sided. 80% is left-sided, 15% is right-sided, and 5% is bilateral. Then history. The first anatomy and pathophysiology of the congenital diaphragmatic hernia was explained by Maculae in 1754. And from the 1905, the first successful repair of the congenital diaphragmatic hernia have occurred. Now, epidemiology. 1/3 of the infants, those who are born with congenital diaphragmatic hernia, are stillborn. Thin and underweight mother have a risk of having infant of congenital diaphragmatic hernia. Mostly the congenital diaphragmatic hernia is sporadic, but means that is mostly sporadic, not familial. But in 10 to 15% of cases, due to abnormal karyotype, the congenital diaphragmatic hernia may be familial. It is mainly occurs in male more than females, and the cause is still unknown. And the drugs that causes congenital diaphragmatic hernia, one most common is Nurofen, which is an herbicide. Apart from that, we can remember one is the thalidomide. We have quinine, cadmium, lead, and phenmetrazine. These are the drugs that can cause congenital diaphragmatic hernia. And vitamin A deficiency also causes congenital diaphragmatic hernia because of retinoid regulatory target genes. Now, what are the associated malformations that are present? Approximately 10 to 15% of the patient of infants with congenital diaphragmatic hernia is associated with malformation. They have skeletal abnormality like limb reduction and costovertebral defect. Apart from that, most common associated, this is important, most common associated anomaly is the neural tube defect. Example, meningomyelocele and more than anencephaly. So most common defect associated anomaly is the neural tube defect. Now, second, we have the cardiac anomalies. And most common cardiac anomaly which occurs in congenital diaphragmatic hernia is VSD, that is ventricular septal defect. Which type of VSD? Perimembranous type of VSD. And there may be urinary tract abnormality. There might be abdominal wall defect like omphalocele and gastrochiasis. Malrotation may be present. Then trisomy of chromosome 21, 13 and 18. And apart from that, what are the syndromes? What are the syndromes that are associated? The syndromes that are associated are WAGR syndrome. What is the full form of WAGR? WAGR is Wilms tumor, aniridia, genitourinary defects and retardation, that is mental retardation. Apart from that, it is associated with Denny-Drash syndrome. It is associated with Wolff-Hirschhorn syndrome, and also associated with like Fryns syndrome. So these are the associated syndromes and associated anomaly that is present in the congenital diaphragmatic hernia. Now we will see the embryological explanation why the congenital diaphragmatic hernia have occurred. Many scientists have given different type of explanation. The number one is theory of mechanical compression. What is theory of mechanical compression? If we understand that, as you know, because of the diaphragmatic hernia, this is the lung and we have the diaphragm. Here the defect is present and the stomach goes up, and this stomach compresses the lung. It compresses the lung. Because of that, there is pulmonary hypoplasia, and because of that, there is also pulmonary hypertension. So this is the theory of mechanical compression. Then we have the dual hit theory. Dual hit theory. we have the dual hit theory. Dual means two hit, first hit, second hit. The first hit is known as when there is bilateral hypoplasia. Because many scientists have seen that always the mechanical compression is not the main theory. There might be bilateral hypoplasia and still the cause is unknown, or the cause may be due to some drugs which caused pulmonary hypoplasia bilaterally, or it is due to genetic causes. And number second is that is mechanical compression. The theory of mechanical compression is the second hit. Then number third, we have patient might be exposed to teratogen, and there is a theory of low air pressure antenatally. It is seen that you have to understand this theory, that is the theory of low air pressure antenatally. It has been seen that we have the trachea, then it divides and we have the lung. It has been seen that if we obstruct the trachea of the child, of the infant, if we obstruct the trachea of the infant, then the lung growth increases and proper lung growth is present. Means the obstruction will cause high pressure, and this high pressure causes lung growth. But here we say the theory of low air pressure means there is low air pressure, because of that the lung growth is not properly present. Now we have the pathology. Pathology of congenital diaphragmatic hernia. Generally the defect which is present in the diaphragm is 2 to 4 centimeter defect over the posterolateral aspect of the diaphragm, and herniation is present. Either both means bilateral lungs are involved or ipsilateral lung is involved. There is presence of abnormal pulmonary bed, and significant adventitial and medial wall thickening of the alveoli is also present. In this patient, in this infants, those who have congenital diaphragmatic hernia, there is reversal of right to left shunt is present in these patients. And there is also a term known as honeymoon phase. What is honeymoon phase? Initially, the infants those who have congenital diaphragmatic hernia, in gestation they look absolutely normal. Baby seems normal. That is the honeymoon phase initially, but later on the infant degrades. Here in the X-ray, now we will see how will you diagnose a case of congenital diaphragmatic hernia. 40 to 90% of cases are diagnosed antenatally. 40 to 90% cases are diagnosed antenatally. And mean gestational age is approximately 24 weeks. Approx in 24 weeks, we diagnose antenatally the infant have congenital diaphragmatic hernia. Clinical clues like what are the symptoms that are present in patient with congenital diaphragmatic hernia. One is polyhydramnios. Polyhydramnios is present in 80% of pregnancy. Stomach is seen in thorax. Here also we can see that the stomach is present in thorax. Stomach is seen in thorax. Even sometimes the liver can also be seen in thorax. And stomach is seen in thorax means stomach is absent in abdomen. So what are the tests that we do? Number one is prenatal ultrasound. prenatal ultrasound, that is at approximately at 20 week, we can identify the congenital diaphragmatic hernia. There will be absence of diaphragm may be present, and intrathoracic pressure is much more higher than the abdomen because of the abdominal viscera. Number second, we can do amniocentesis. What is amniocentesis? Amniocentesis, as you know, I have said earlier also, the congenital diaphragmatic hernia is majorly sporadic, but in 10 to 15% of cases it may be because of the genetic defect. Because of that, we have to do amniocentesis. Number third is important, that is LHR, that is lung head ratio. LHR is lung head ratio. Prognostic marker for, this is a prognostic marker for fetal lung hypoplasia, calculated using ultrasound. This is calculated using USG, and area of contralateral lung by fetal head circumference. Area of lung, area of contralateral lung by fetal head circumference. If this is less than 0.85, then the patient will have 100% mortality. Remember this. This is lung head ratio. Lung area, contralateral lung area, fetal head circumference. If it is less than 0.85, then patient will have 100% mortality. So this is number third, that is we have seen the prenatal ultrasound, amniocentesis, lung head ratio. Apart from that, number fourth is lung by thorax in transverse axis. Then we have prenatal MRI. There may be absence of liver in the abdomen. Position of the stomach is important, and most common is McGoon index. McGoon index. We will see later on in this video. So now we will see how will you do the assessment of the patient. In the assessment of the patient, what are the tests that we will do? Number one is ABG, that is atrial blood gas. Number second is the 2D echo. As I have said, most commonly the cardiac anomaly which is present is VSD. We can assess the VSD in these patients, and in 2D echo we will see the McGoon index. McGoon index. So what is McGoon index? This is important. So McGoon index is right pulmonary artery diameter, okay, plus left pulmonary artery diameter divided by descending aorta diameter. Okay, right pulmonary artery diameter plus left pulmonary artery diameter is equal to the divided by the descending aorta diameter. This is the McGoon index. If the McGoon index is less than 1.31, this is a good prognostic factor. This is a good prognostic factor. So you have to remember the McGoon index, and if it is less than 1.31, then it is a good prognostic factor. Apart from that, another that you can just remember is the pulmonary artery index, that is right pulmonary artery area plus left pulmonary artery area divided by basal surface area. This is the pulmonary artery index. Now, what are the differential diagnosis of this diaphragmatic hernia, congenital diaphragmatic hernia? Number one is eventuation of diaphragm. means the diaphragm is pulled up, that is eventration of diaphragm. Then anterior diaphragmatic hernia, that is Morgagni hernia. Then we can have congenital esophageal hiatal hernia, and we have congenital cystic disease of lung. Congenital cystic disease of lung. Now we will see the management. What are the preoperative care? Preoperative care is, number one, we need to stabilize the patient first. If there is need for intubation, we will intubate the patient. It is a physiological emergency, not a surgical emergency, as I have mentioned earlier. And we have to do, we can intubate the patient. We will put Ryle's tube. And remember, note, bag, mask, ventilation. Bag mask ventilation is not done in cases of congenital diaphragmatic hernia. Apart from that, we will see thermoregulation, glucose monitoring, hemodynamic stability, and proper sedation. Fine. These are the preoperative care. Apart from that, in preoperative treatment, we have to give HFOV. What is this? This is high frequency oscillatory ventilation. Okay, high frequency oscillatory ventilation is also given, and it has been seen that it is efficient. Apart from that, you can give partial liquid ventilation. Now we will see the pharmacotherapy. In cases of, one thing is more important, in cases of congenital diaphragmatic hernia, the PaO2 is maintained at 55 to 60 mm of Hg for infants, and then PaCO2 is maintained at 60 mm of Hg. We keep the patient in permissive hypercapnia, and we give low pressure. We use low pressure and high frequency ventilation, and we also maintain mild alkalosis in the infants of congenital diaphragmatic hernia. These are also perioperative care. Now, what are the pharmacology to improve pulmonary? There is, in patient have pulmonary hypertension. What are the drugs that you can use to decrease the pulmonary hypertension? One is nitroprusside. Then we have nitroglycerin. We have captopril. We can use calcium channel blockers, prostaglandin derivative, and endothelin receptor antagonist. So these are the drugs which are used. The proper inhalation of nitric oxide and surfactant, the use of these two substances are inconclusive, not proven yet. These are generally not used. Now, what is ECMO? ECMO is offered to 10 to 20% of cases in congenital diaphragmatic hernia. Those patients who have severe, ECMO is given in patients who have severe hypoplasia. for preoperative and surgical stabilization. What is ECMO? ECMO is where the lung is bypassed, and ECMO allows gaseous exchange through arteriovenous and venovenous circulation connected to a membranous gas exchange, thus protecting the lung from the barotrauma. That is the ECMO. Level of evidence to support the ECMO is still very weak. No proper evidence is seen in cases of congenital diaphragmatic hernia. So what are the operative criteria? Either we can treat the patient immediately, or we can treat the patient after some time, that is delayed treatment. Most commonly preferred option is abdominal approach. We generally do the abdominal approach. And we, apart from abdominal approach, we use ICD, that is intercostal drain in thorax, after operation or during operation, and the defect is repaired. Defect that is present in the diaphragm, defect is repaired by the use of mesh. We can use mesh, or we can use LD flap also, that is latissimus dorsi flap. The role of minimal invasive surgery in this, role of minimal invasive surgery. The role of minimal invasive surgery is we can do thoracoscopy, that is VATS, and thoracoscopy is done in stable infants. In unstable infant, we do the abdominal approach. So what is the prognosis of this patient at last? The prognosis is still it is seen that survival is present in, survival rate is 50 to only 60%. Risk of pneumonia. These infants have risk of pneumonia 35% by 12 years, and in first 3 years they have a risk of viral bronchitis by which virus? RSV virus, respiratory syncytial virus. And these patients also have future, they can suffer from GERD. Then the treatment of GERD is prophylactic. We can also do prophylactic fundoplication. And neurological developmental delay is present. So conclusion of this topic is CDH is a spectrum which ranges from severe pulmonary hypoplasia and pulmonary hypertension, non-responsive to conventional management, and these are managed now medically as emergency procedure, and later on it can be managed via the delayed procedure. And it is still a mystery for the neonatologist and the pediatric surgeon also. Thank you for today's video. Guys, thank you for listening. In our next topic, we will continue with further topics of the pediatric surgery. Please do like, share and subscribe to support me so that I can make further interesting videos for you guys. Thank you.